Minimally invasive surgery for glaucoma, ab interno trabeculectomy with the trabectome. The primary author, Brian Francis, has a consultant agreement with Medici. Aqueous outflow and decreased outflow facility is recognized as the major pathology in open-angle glaucoma. Traditional filtering surgery bypasses the outflow pathway but results in problems related to hypotony and external filtration such as infection and bleb dysesthesia. The trabecular meshwork is considered the main factor in outflow resistance in primary open-angle glaucoma. This is true if you view the trabecular meshwork as a static semi-permeable tissue, or if you view it as a dynamic flexible tissue which eventually collapses Schlemm's canal at high intraocular pressure. The concept of opening trabecular meshwork and Schlemm's canal inner wall theoretically improves outflow facility by creating a pathway from the anterior chamber directly into the collector channels. The challenge before us is to design a system that can permanently open a pathway through trabecular meshwork and into Schlemm's canal and gain access from the anterior chamber to the aqueous collector channels. The Trabectome system goals are to excise a strip of trabecular meshwork and inner wall of Schlemm's canal, such that the edges of trabecular meshwork will not reapproximate or fibrose. Selective ablation must be attained. The anterior chamber must be maintained throughout the procedure, and there must be a clear view of the angle during the procedure. The Trabectome system consists of a handpiece, a console with irrigation and aspiration, an electrocautery generator, and a foot pedal control. The Trabectome surgical technique. First, a corneal or scleral incision is made with a 1.6 mm keratome. Then injection of viscoelastic and/or preservative-free lidocaine anesthetic. The angle view is verified with a gonio lens. Then the tip is inserted into the anterior chamber and the gonio lens is replaced. Then there is a clear view through the gonio lens of the angle and the tip of the instrument as it approaches the angle. The Trabectome handpiece tip, which has irrigation ports as well as aspiration. There is also an electrocautery generator with a return electrode and active electrode. Next, there is the insulating protective sleeve, which serves a dual purpose of protecting thermosensitive structures such as external wall of Schlemm's canal and also guiding the cautery generator along inside of Schlemm's canal as the tip is advanced. The sharp tip is inserted into the trabecular meshwork, and then the handpiece is rotated first in a counterclockwise direction and then turned over 180 degrees, and ablation is performed in the clockwise direction. Note that there is some reflux of blood from Schlemm's canal and opened collector channels. Finally, there's irrigation and aspiration of viscoelastic fluid and a corneal suture placed. Theoretically, this then reestablishes outflow through the normal trabecular meshwork and Schlemm's canal outflow pathway. Studies have been published regarding the histopathology and proof of concept of the device. The procedure was used in a donor corneal scleral rim, as shown here. Histopathology specimen shows on the left a control specimen with an intact trabecular meshwork and Schlemm's canal. On the right is a trabectome done at a low power 0.3 watts, which shows a clear separation of the trabecular meshwork flaps. On the left is shown a higher power ablation with a trabectome 0.5 watts, and on the right 0.7 watt ablation. In both of these pictures you can see a clear separation of the trabecular beams and access from the anterior chamber into Schlemm's canal. A goniotomy specimen shows a slit-like entrance into Schlemm's canal on the left and a higher magnification of this on the right. One goniotomy specimen showed deep penetration of the slice into the scleral tissues. The trabectome procedure is shown here. Initially there is a corneal incision, viscoelastic or a lidocaine or other anesthetic is injected intracamerally. The gonio lens is placed on the eye and the tip is advanced across the anterior chamber, and the initial trabecular meshwork removal is initiated. Here you can see some reflux of blood from the opened cleft into Schlemm's canal. Following the initial pass, the handpiece is rotated 180 degrees. The trabecular meshwork ablation is then performed in the opposite direction. In this manner, approximately 90 degrees or 3 clock hours of trabecular meshwork ablation can be performed. At the end of the procedure, a suture is placed. There is a washout with BSS of the anterior chamber, blood and or viscoelastic, and an air bubble tamponade can be used to prevent further bleeding. Patient selection is critical for success with trabectome. There must be an open angle with a clear gonioscopic view and a deep anterior chamber, which can be maintained with irrigation. The structures of the angle must be clearly viewable through a gonioscopic lens. The intraocular pressure goal should be in the mid-teens. In conclusion, we believe that trabectome is true outflow surgery, which is not relying upon external filtration. This reduces the risks of complications seen in external filtering surgeries, such as those related to hypotony or infection. We feel that this has a place as a primary glaucoma surgical procedure and has a great advantage of sparing the conjunctiva for future use.